Good evening, everybody, and yeah, happy holidays. And I guess we can tell who the very dedicated students are by those of you who have joined us tonight. And so, yeah, thank you for joining us for this session of Therapy Ed's online office hours. My name is Tom Sutliff. I'm going to be the co-host for tonight's session. I'm one of the Therapy Ed instructors. I'm one of the co-editors for Therapy Ed's Review and Study Guide, and I'm on faculty in the Army Baylor University program here in San Antonio, Texas, and that's where I met our guest speaker for tonight, and we'll let Mike tell you a little bit more about himself in just a moment, but. Yeah, exciting times. I'm going to make the assumption that a number of you are going to be taking the examination in January. But if you could just go ahead and light up the chat box and tell us when you're planning to take the examination. So are you taking it in January or okay, so Lindsay, so January 23rd, April. So January and April so far, it looks like most of you are going to be taking the examination at that time. Anybody else want to chime in? So yeah, so just in February. Okay, I didn't know there were any February dates, Ria. I guess maybe there's some spillover from from the January, the end of January testing dates, and in October. So those of you who are taking the exam in October, as we like to say, there's no substitute for early preparation, and we're glad that you've joined us. Glad that all of you have joined us for tonight's class. And so, yeah, tonight's speaker is Dr. Mike Crowell. Dr. Crowell is now an associate professor, and he's on faculty in the University of Scranton DPT program. Where I knew him was first as a student and then as a therapist in the United States Army. He served for more than 20 years on active duty in the Army as a PT, and he retired as a lieutenant colonel. Most recently, he was the director of the Sports Medicine Fellowship Program up at West Point at the United States Military Academy. Mike is also one of the authors or the co-author of the musculoskeletal chapter in our Therapy Ed Review and Study Guide. And so we're fortunate tonight to have one of our authors in the room, and he's presenting on what I think you're going to find to be a very relevant topic. I'm confident that you're going to see a number of questions on the NPTE that deal with knee injuries. And so Mike's going to be covering the clinical practice guidelines for knee ligament and cartilage injuries as well. And so, Mike, as always, thank you for your service to our country. Thank you for taking the time to do the presentation tonight and to share your knowledge and experience and expertise with the students. And the Zoom room is all yours.
Well, thank you very much, Dr. Sutliff, for the great introduction, as always. Always a little bit embarrassing to hear him talk about me like that. But so yeah, I am currently an associate professor at the University of Scranton. I just started teaching their orthopedic content this year, but I recently retired from the Army as a lieutenant colonel with a little over 24 years. So a little bit of a unique career. You can see some of the pictures there on the right of the slide. I actually started off as a field artillery officer before I went to PT school, and spent 4 years stationed in Bamberg, Germany, which was an awesome experience as far as just personally getting to travel Europe, and then leadership, being a platoon leader and executive officer of like real Army units. I was in a field artillery unit over there. But then the rest of the time in the Army has been as a physical therapist. So I just left West Point as their fellowship director for the West Point Division I Sports Physical Therapy Fellowship. And I spent about almost 10 years of my career there with a really great assignment. I loved every minute of teaching those sports fellows. Well, while I was in the Army, I've had a variety of clinical and leadership roles. Like I said, I was at West Point for the longest time, but I also worked at the Army Surgeon General's office on a health and wellness project called the Performance Triad. I deployed with the 101st Airborne Division as a brigade physical therapist. So I was taking care of their musculoskeletal complaints for about 4,000 to 5,000 active duty soldiers. Great experience there. I mean, that was one of the most professionally rewarding things. Being away from my family for 15 months wasn't the greatest, but it was a great experience as far as being a PT and getting to do some really cool things. But with that being said, let's go ahead and get into it. And so here's the objectives for tonight. We're going to talk about two sets of clinical practice guidelines. The first one is the knee ligament sprain clinical practice guidelines, and then the second one involves meniscal and articular cartilage lesions. And then at the end, we'll answer some simulated national licensure questions in the areas of examination, evaluation, and intervention. On some of the slides there below, you're going to see that little icon, the bonus content. This is information that's a little bit above and beyond the CPG. It's unlikely to be directly tested on the NPTE, but I think it's going to provide you some additional depth and context, which may help to answer questions and be useful in clinical practice. It's also going to hopefully make this a lot more interesting. So I got a couple of cool video slides that I'll show you when we go into that. But before we do that, let's look at the exam as a whole. So the big thing I think you can see from this figure here is that the musculoskeletal content is the greatest content on the NPTE at almost 27%. And now when you look at the areas of examination, evaluation, and intervention, those are your big three. You can see how that's split up about a third to a quarter for each of those areas. But the evaluation, differential diagnosis, and prognosis is probably the most of those. And then when you break it down, so if you look at musculoskeletal, neuromuscular, and cardiopulmonary, that's 65% of the exam. And then if you break it down based on the number of questions that you're likely to see, so for examination within musculoskeletal, you could see anywhere from 14 to 18 questions with an average of about 16. Within the evaluation section, you could see 15 to 18 with an average of about 16. And then within intervention, you could see 15 to 18 with an average of 17. So overall, on the exam, you could look at anywhere from 44 to 54 questions are going to involve something related to musculoskeletal. All right, now before we get into the clinical practice guidelines, we're just going to review the relevant anatomy and biomechanics of the knee joint. So first, just some general anatomic considerations. The ACL and the PCL, remember that those are both intracapsular and extrasynovial. Remember that the medial tibial plateau is slightly larger than the lateral tibial plateau, and these kind of make a difference in some of the clinical situations and some of the biomechanics. The ACL is attached attached distally to the tibia on the lateral and anterior aspect of the medial intercondylar tibial spine, and it extends superiorly, laterally, and posteriorly to attach to the posterior medial aspect of the lateral femoral condyle. It twists inwardly or medially as it travels proximally. And then you have the PCL, which is attached distally to the posterior tibial surface between the posterior horns of the two menisci. And it travels superiorly and somewhat anteriorly to attach to the lateral aspect of the medial femoral condyle. The MCL is divided into a superficial portion and a deep portion. The superficial portion arises proximally from the medial femoral condyle. It travels distally to insert into the medial aspect of the proximal tibia, which is just distal to the pes anserine. And then the deep portion is continuous with the joint capsule and originates from the inferior aspect of the medial femoral condyle and inserts on the proximal aspect of the medial tibial plateau. And lastly, the LCL is attached proximally from the lateral femoral condyle, travels distally to the fibular head, and there it joins the tendon of the biceps femoris muscle to form the conjoined tendon. Now, unlike the MCL, it's not a thickening of the capsule, but it's separate throughout much of its length, and it's therefore considered to be an extracapsular ligament. The medial meniscus is a large and C-shaped and attaches to the MCL and fibrous capsule. There's additional attachments to the submembranosus muscle and the medial meniscopatellar ligament. The lateral meniscus is smaller than the medial meniscus and it's more circular. And as you can see on the figure here, a little bit more circular. And it's attached to the popliteus muscle, lateral meniscopatellar ligament, and the meniscofemoral ligament. Now, for biomechanics, let's focus on the tibiofemoral or the true knee joint. So the knee is a double condyloid joint with 2 degrees of freedom. In the sagittal plane, normal flexion range is 130 to 140 degrees, and extension range is from 5 to 10 degrees of hyperextension. The axis of motion for flexion and extension is an oblique angle through the condyles, and this is because the medial femoral condyle extends slightly farther distally. In the transverse plane, medial lateral rotation is approximately 35 degrees at 90 degrees of knee flexion. And lateral rotation is slightly more than medial, and the magnitude of rotation is decreased at end range flexion and extension. Flexion and extension are a combination of both roll and glide, as you can see in the figure over here. With knee flexion, posterior rolling of the femoral condyles tensions the ACL, and that results in an anterior translational force. With knee extension, anterior rolling of the femur tensions the PCL, and that results in a posterior translational force. The menisci serve multiple functions. They serve to deepen the fossa of the tibia, increase congruency of the tibia and femur, provide stability to the tibia-femoral joint, provide shock absorption and lubrication to the knee, reduce friction during movement, and then also improve weight distribution. And generally, the menisci follow the tibia with flexion and extension, and the condyles with internal and external rotation. So now let's get into the practice guidelines, and we'll start off with the knee ligament sprain clinical practice guidelines. So ACL injuries are the most common knee injury, with 80 to 250,000 injuries per year in the US, with approximately 100,000 ACL reconstructions being performed annually. The risk of ACL injury is highest in sports that require multi-directional activities, such as rapid deceleration, pivoting, cutting, and landing from jumps. Approximately 70% of all ACL injuries are non-contact. ACL injury rates are 2 to 10 times higher in female athletes when you compare it to male athletes of similar age in sports. Depending on the clinical setting, PCL injuries account for approximately 1 to 44% of all knee injuries, and a classic mechanism for a PCL injury is a dashboard impact to the knee during a motor vehicle accident. PCL injuries are also common in sports such as soccer. Collateral ligaments account for 4 to 8% of all sports injuries. LCL injuries are usually a component of the more extensive posterior lateral corner injury. The two most common multi-ligament knee injuries involve the ACL and the MCL, or the posterior lateral corner with the ACL. The vast majority of research on risk factors in clinical course involves the ACL. And while the majority of athletes return to sport after ACL injury, many fail to return to pre-injury levels of competition, or they also suffer from loss of performance. And risk factors for ACL injuries include female sex, narrow intercondylar femoral notch size, lesser concavity depth of the medial tibial plateau, greater anterior to posterior tibia-femoral joint laxity, prior ACL reconstruction, and then familial predisposition. A high-quality exam of the knee involves both key information from the subjective and the objective portion. The mechanisms of injury for each of the major ligaments are different. ACL injuries involve cutting, twisting, or landing with a valgus load. PCL injuries typically involve either a posterior tibial force or hyperextension. And MCL injuries involve valgus force or trauma, and LCL injuries involve a varus force or trauma. In the subjective portion of the exam, patients with ACL injuries often report hearing or feeling a pop at the time of the injury. They may also report hemarthrosis or effusion very rapidly after the injury occurs, and they complain of giving way or a feeling of instability in the knee. Patients with PCL injuries complain of posterior knee pain, although the degree of effusion is not as profound as with an ACL injury. Patients with lateral collateral ligament injuries may report localized lateral swelling of the knee. In the objective portion of the exam for all knee injuries, clinicians should assess knee joint range of motion, effusion, thigh muscle strength, lower extremity movement coordination, and knee stability. The two best special tests for ACL injuries are the Lachman test for straight plane anterior instability and the pivot shift test for anterior lateral rotor instability. The Lachman test is graded by both the amount of anterior translation present and the end feel. It's essential to perform all these ligamentous stability tests on the uninvolved knee first to accurately gauge the normal laxity for any given patient. While the Lachman test is usually well tolerated, even acutely after a knee injury, it's frequently difficult to get the patient to relax enough to perform a pivot shift test effectively. Surgeons typically perform the pivot shift under anesthesia, which increases the diagnostic accuracy. The best special tests for the PCL are the posterior drawer test for straight plane posterior instability and the SAG sign. The posterior drawer test is graded by the amount of posterior translation present and also the end feel, while the SAG sign is graded as either positive for a SAG sign present or negative for a SAG sign absent. Special tests for the collateral ligaments are the valgus stress test for the MCL and the varus stress test for the LCL. Varus or valgus stress is applied with the knee positioned in both 0 and 30 degrees of knee flexion. And the test is positive when it reproduces either familiar pain or laxity. A positive finding of increased laxity at 0 degrees of knee flexion indicates a major disruption of the knee, with one or more of the rotary tests also likely to be positive. And patients may also present with tenderness to palpation at the MCL or the LCL. Now, as I discussed earlier, the major mechanisms of injury for the ACL involve cutting, sidestepping, or jump landing. Jump landings could be either a double leg landing, like those that frequently occur during basketball, or a single leg landing, like those that frequently happen in European team handball. A commonly observed characteristic of ACL injuries is a rear foot strike with the knee in nearly full extension. Athletes that tear their ACL are also frequently off balance, and they may have been bumped by another player, or there simply may be other players close by. All knee injuries may be partial tears, complete tears, or avulsions. And in pediatric patients, ACL injuries may present as a tibial spine fracture, as the ligaments are stronger than bone at that stage of development. This picture shows the impressive amount of subluxation that occurs immediately after the tear of the ACL. The sister of this player was the one that took this picture. So she had an MRI that showed an ACL and a medial meniscus tear, and eventually she had an ACL reconstruction. But you can see in the red circle the amount of subluxation of the tibia that occurs when the injury happens. So these are some videos. Hopefully you'll enjoy seeing these. And you'll get to the point, I think, now when I watch a football game or a basketball game and somebody goes down with a knee injury, you can almost tell right away if it's an ACL injury based on how these look. So the first one here, this is what a double leg landing looks like. And so this will loop through as we're going. And so I'll highlight here a couple things. So the knee that you want to look at up here is the right knee that kind of collapses inward as she lands. So you can see it here and here. So I'm sorry, that's the left knee. So right there, looking at her left knee and how it kind of collapses inward as she lands. So that is a double leg landing. A lot of female basketball players and female athletes in general tend to move with this pattern with a lot of knee valgus as they land. And so this is a plant and cut injury. So a couple of these next videos are going to be from soccer. So this one, I wasn't able to slow it down, and it goes a little bit faster, but number 11 there is coming up to make a play on the ball, and he plants that right foot way outside of his base of support. The knee is almost fully extended, as I talked about in that last slide, and you can see how he collapses down into that knee valgus position. So what I'll do here is I'll slow this down a little bit, and you can see as he comes out there, and then that knee goes into valgus. You don't see it as much because his knee is almost in full extension, but this shows it at at that freeze frame position. And so as he's kind of coming out and trying to make that plant and cut stop and come back to his left. So this is from soccer as well. This is an example of a single leg landing. So not quite as impressive. And if I slow it down, he kicks with the right. And so now we'll show you the freeze frame here. So that position right there when he comes down to land after that kick. So he kicks it with his right leg, and as he's going to land, that's the position there that he lands in, and then he starts moving into that valgus position, and then he eventually collapses. So one of the questions that I'll typically ask a patient if they've had a suspected ACL injury is, what right at the time of injury did you fall to the ground? And so one of the common things you've seen from these past 3 videos is right after the moment of the injury, that player is kind of down on the ground. And so that's a typical question I'll ask a patient. And so skiing is really different. These injuries are kind of wacky. So I just put one of them in here to give you an example, but it's not like it is with a jump landing or a plant and cut type of thing. So going a lot faster, a lot more out of control. Things happen super fast. And so there, you almost don't even see what happens. And so this is going to loop through again. And if you watch that skier as he starts to turn, he loses contact with the snow with the right ski. So he loses contact right there. And now as he goes to reestablish the contact with that ski, the that friction force really jams his knee into that kind of valgus position. And so as you see it right here, that ski starts to engage the snow. And once it catches, it throws him right into that valgus position. So it happens really, really fast. And so that's the freeze frame of it right there. So a little bit different mechanism with skiing. Again, this is some bonus content and just kind of gives you a good idea of how these ACL injuries actually occur. So now we're going to get into the diagnostic accuracy for special tests in the knee, but before we do that, let's review the definitions for sensitivity, specificity, and likelihood ratios. So sensitivity is a test's ability to obtain a positive test when the target condition is really present or a true positive. And we use the mnemonic SNOUT, so a sensitive test with a negative result helps us rule out a condition. And the formula for sensitivity is the true positives divided by the true positives plus the false negatives, or A over A plus C. Specificity is a test's ability to obtain a negative test when the condition is really absent or a true negative. And we use the mnemonic SPIN, so a specific test with a positive result helps us rule in conditions. And so the formula for specificity is true negatives divided by false positive plus true negatives, or D over B plus D. But the weakness of sensitivity and specificity is they're influenced by the prevalence of the condition in the studies that report those diagnostic accuracy statistics. So likelihood ratios tell us the probability that a patient has the condition after the test is done, and they're independent of disease prevalence. Formula for a positive likelihood ratio is the sensitivity divided by 1 minus the specificity, and the formula for a negative likelihood ratio is 1 minus the sensitivity divided by the specificity. Tests with a small negative likelihood ratio could be used early in the exam to rule out alternative diagnoses. And tests with a large positive likelihood ratio could be used late in the exam to rule in the primary diagnosis. So let's use an example nomogram here on the right for a condition with a pretest probability of 30%, which is on the left-hand column here. So we're going to go to 30%. A test with a negative likelihood ratio of 0.2 is going to result in a post-test probability of 5 to 6%. And now alternatively, a positive test and with a test with a positive likelihood ratio of approximately 3 is going to yield a post-test probability of almost 60%. So that gives you an idea of how you can use these tests to judge how likely or unlikely a patient may have a certain diagnosis. So in this table that's from the Therapy Ed NPTE Review and Study Guide, shown in the red boxes are going to be the best tests. So the Lachman test is the best test for one plane anterior instability with good sensitivity, specificity, and likelihood ratios. The anterior drawer test is more specific than sensitive with a better positive likelihood ratio than a negative likelihood ratio. So this means, like as we discussed in the last couple slides, that while a positive test increases the probability of an ACL injury, a negative test is not as meaningful. The pivot shift test is the best test for anterolateral rotary instability. And as we discussed previously, it's a difficult test to perform. So the sensitivity and likelihood ratios are much better when the test is performed with anesthesia than it's performed without anesthesia. Now, despite the fact that the Lachman test is the best test for the integrity of the ACL, I found when I'm teaching students and interns, residents, and fellows, that it's frequently performed and interpreted poorly. And shown on this slide are the two most common methods for performing a Lachman test. So in the textbook Orthopedic Physical Examination, the McGee textbook, they describe 8 different modifications of the Lachman test that can account for different anatomic variations in both the examiner and the patient. But regardless of the method of the assessment, the principles are going to remain the same. The knee should be placed in 20 to 30 degrees of knee flexion. With the femur stabilized, the examiner is going to translate the tibia anteriorly on a plane that's parallel to the tibial plateau. And then a positive test is indicated by a soft end feel and excessive tibial translation when it's compared to the uninvolved leg. Now, according to McGee, disappearance of the infrapatellar tendon slope is also a positive finding. And also, according to McGee, a false negative test may be the result of not properly stabilizing the femur, a flipped bucket handle meniscus tear that's blocking translation, or if the tibia is medially rotated. So the posterior drawer test and the sag sign are the best special tests for one plane posterior instability. These tests have not been studied as extensively as this test for the ACL, but based on the best available evidence, both tests appear to have good diagnostic accuracy. Tests for medial instability have been studied with enough frequency to assess diagnostic accuracy. So both positive and negative results accounting for both pain and laxity result in moderate shifts in probability for medial instability. However, the various stress test has not been evaluated formally. It's likely due to the relative rarity of isolated LCL injuries. It's important to assess physical performance in patients with knee ligament sprains. So hop testing is a practical physical performance measure that assesses strength, neuromuscular control, and confidence. And single leg hop tests are the most common hop tests that will be utilized to assess baseline pain, function, and disability, assess symmetry with regard to the unaffected limb, evaluate the patient for return to activity or sports, and also to evaluate the effectiveness of treatment programs by measuring changes during treatment. So there's multiple forms of single leg hop tests, include the single leg hop for distance, a crossover hop for distance, a triple hop for distance, and the timed 6-meter hop. Clinicians should also use validated patient-reported outcome measures when they're appropriate. So to assess for knee symptoms and function, you should use the International Knee Documentation Committee 2000 form, which is also known as the IKDC 2000. The Knee Injury and Osteoarthritis Outcome Score, also known as the KOOS, and or the Ligament Knee Scoring Scale. To assess activity level, you should use the Tegner scale, or the Marks Activity Rating Scale. The Tegner scale groups activities into levels based on their degree of stress on the knee. So level 10 is competitive elite level sports, while level 1 is sedentary work. Now, the Ligament and Tegner scales are frequently utilized together. After an ACL injury, assessment of psychosocial factors is also important. The ACL cruciate ligament return to sport index assesses psychological factors that may hinder return to sports. There are many interventions that are available to physical therapists for the rehabilitation of patients with knee ligament sprains. For this presentation, we're going to focus on those interventions that were rated as having A-level evidence with a strong recommendation in the clinical practice guidelines. To increase muscle strength and performance after ACL reconstruction, both weight-bearing and non-weight-bearing concentric and eccentric resistance exercises should be started within 4 to 6 weeks. These exercises should be performed 2 to 3 times per week for at least 6 to 10 months post-operatively. If a patient with an ACL tear is treated non-operatively, you can use these recommendations similarly, although they were not included in this guideline. Also not included in the guideline, it's been my experience that patients may need to continue to perform these exercises for up to 1 to 2 years after surgery. After ACL reconstruction, muscle inhibition is a frequently encountered problem, particularly early on. Neuromuscular electrical stimulation should be utilized for 6 to 8 weeks in conjunction with muscle strengthening exercises. And there have been a variety of parameters that were studied with the effect sizes ranging from small to very large. In patients with knee stability and movement coordination impairments after knee ligament sprain, which is pretty much almost every patient, neuromuscular training should be incorporated with muscle strengthening exercises. Neuromuscular training incorporates 3-dimensional movements of progressively greater speed and difficulty, while emphasizing proper jump landing and balancing techniques. Examples may include static and dynamic single leg balance exercises, single and double leg jump landing exercises, and trunk stability exercises. All right, so now let's move on to the meniscal and articular cartilage lesion clinical practice guidelines. So injuries to the menisci are the second most common knee injury, accounting for almost 1/4 of all knee injuries. They frequently occur in combination with ACL injuries. Older people have a higher incidence of meniscus tears in general, and medial tears specifically compared to younger people. Younger athletes are more likely to have lateral injuries. Risk factors for chronic meniscal tears are greater patient age and increased knee laxity after ACL injury. Cutting and pivot sports, those are risk factors for acute meniscal tears. While the rates of meniscal surgery have increased over the past decade, recent research has shown that patients who are given non-operative treatment have similar outcomes to those who undergo surgery. And in younger patients, meniscus repair is preferred over meniscectomy to preserve the health of the articular cartilage. The prevalence of articular cartilage lesions in athletes' knees ranges from 27 to 59%, although many of these are asymptomatic. Articular cartilage lesions frequently occur after partial meniscectomy or a second ACL injury. A major risk factor for articular cartilage injury is the presence of a meniscal tear. Although return to activity after articular cartilage surgery is high, failure and reoperation rates are also high. In female sex, older age, higher BMI, longer symptom duration, prior surgery, and lower self-reported knee function are associated with higher failure rates after articular cartilage repair. The most common mechanism of injury for an acute meniscus tear is a twisting type of injury, and chronic meniscal tears and articular cartilage lesions do not have a typical mechanism that produces an injury, and so the patient may not even remember a specific traumatic event. Patients with articular cartilage lesions frequently report that their symptoms are aggravated by repetitive impact activities such as running and jumping. In the subjective portion of the exam, patients with acute meniscal tears describe feeling or hearing a pop at the time of injury, kind of like an ACL tear, but it's a little bit less profound. But they report delayed effusion, with the onset being 6 to 24 hours post-injury, whereas the ACL injuries, again, they'll have immediate swelling. Patients with articular cartilage lesions describe intermittent pain and swelling. If an osteochondral fracture is present, the patient may describe acute trauma with a hemarthrosis. And patients with both meniscal tears and articular cartilage lesions may report knee locking or catching. And as stated previously, in the objective portion of the exam for all knee injuries, you should assess knee joint range of motion, effusion, thigh muscle strength, and lower extremity movement coordination, in addition to knee stability. Patients with meniscal tears will frequently have pain when overpressure is applied to the end range of knee flexion or extension, while patients with meniscal tears and articular cartilage lesions will both have tenderness to palpation at the affected joint lines. Additional special tests that should be utilized to diagnose meniscal injuries include the Thessaly test and the McMurray test. These are the two best tests for meniscal injuries, and both of these are pain provocation tests. For the McMurray test, the lateral meniscus is tested by passively internally rotating the tibia while extending the knee, while the medial meniscus is tested by externally rotating the tibia while extending the knee. And then the Thessaly test, that's performed as standing on the involved leg and rotating the body and leg internally and externally. The test is repeated with the knee in both 5 and then 20 degrees of knee flexion. And then a positive finding in both tests is reproduction of a click or pain in the knee joint that's in the same area as their chief complaint. Much like with low back pain, imaging findings of meniscus tears in asymptomatic individuals are common as patients age. So the prevalence of asymptomatic meniscus tears ranges from approximately 5% in younger ages to up to 67% in older ages. So a variety of tear patterns can be present. The type of tear and the age of the patient influence the choice of the intervention. Radial tears are the most common, shown here, but they have a poor capacity for healing because they mostly occur in the area of the meniscus that's avascular. Parrot beak tears are different from radial tears in that the tear is curved like a parrot's beak. Vertical or horizontal tears involve disruption that's parallel to the circumferential fibers of the meniscus, and these tears are often repairable. Bucket handle tears are a form of a vertical tear where the torn piece of the meniscus tissue is displaced. And these tears may flip displaced tissue into a variety of areas in the joint, potentially creating a block to motion. And if this occurs, surgery is warranted acutely, very soon, because you need to really prevent the loss of knee motion. Flap tears are similar to bucket handle tears, except they don't account for the full thickness of the meniscus tissue. And lastly, acute tears from excessive force while acute tears are from excessive force that's applied to normal tissue, degenerative tears, like the one shown here, are the result from repetitive normal forces applied to abnormal tissue. And degenerative tears typically have a complex tear pattern. That's what you see in that bottom circle right there. The incidence of each tear pattern is also different based on the patient's age. In younger athletic patients, acute tears are more common. They're often bucket handle tears, as shown in the top red circle. Chronic meniscal tears are common in older individuals and are often degenerative tears, as shown in the lower red circle. So as stated previously, recent evidence suggests that non-operative treatment is equivalent to surgery for these degenerative type of tears. In this table from the review and study guide, shown are the best individual tests for meniscal tears, along with the diagnostic accuracy for a combination of tests. The McMurray and Thessaly test appear to be somewhat more specific than sensitive. Therefore, the presence of a positive test appears more useful to rule in a meniscus tear then a negative test is useful to rule out a meniscus tear. Combinations of tests appear to be better than individual tests in the diagnosis of meniscal tears. Each combination includes joint line tenderness and adds other elements such as the McMurray test, the Thessaly test, joint effusion, knee flexion overpressure, and the squat test. Now, as with the knee ligament sprains, it's important to also assess physical performance and self-reported function in patients with meniscal and articular cartilage lesions. But these recommendations are no different from those that we've discussed previously, so I'm going to move past this. Again, as with knee ligament sprains, there's many interventions available for the rehabilitation of patients with meniscal and articular cartilage lesions. There's not as much research on interventions as there was for knee ligament sprains, so we'll focus on those interventions that were rated as having B-level evidence with a moderate recommendation in the clinical practice guidelines. Progressive active and passive knee motion may be utilized early in the rehabilitation of patients after both meniscal and articular cartilage surgery, and post-surgical rehabilitation guidelines typically limit end-range flexion and meniscal repairs. Following articular cartilage surgery, clinicians should use a stepwise progression of weight bearing. Full weight bearing should be achieved within 6 to 8 weeks, and this may be achieved with the patient non-weight bearing for the first 2 weeks, then partial weight bearing at 25% for 1 week, 50% for 1 week, 75% for 1 week, and then finally full weight bearing at 6 weeks post-surgery. As with most musculoskeletal conditions, therapeutic exercise is a mainstay of the treatment, and clinicians should provide supervised progressive range of motion exercises and progressive resistance training of the knee and hip muscles. Neuromuscular training that includes static and dynamic balance exercises and plyometrics should also be included. Neuromuscular electrical stimulation is an adjunct intervention that may be utilized. Following meniscus repair surgery, clinicians should utilize neuromuscular electrical stimulation to increase quadricep muscle performance and the knee function. Evidence for optimal parameters after knee surgery is lacking, but there's evidence that currently exists for ACL reconstruction that can provide a framework. And lastly, clinicians should use supervised rehabilitation programs after arthroscopic meniscectomy. And they should also provide and supervise the progression of a home-based exercise program, providing education to ensure correct and compliant performance. Fractures of the tibia, fibula, or patella may also occur with traumatic injuries to the knee. The Ottawa knee rules were developed and validated to assist clinicians with the decision to order radiographs when a patient has an acute traumatic knee injury. The Ottawa knee rule has a sensitivity of 0.99 and a negative likelihood ratio of 0.05, which means that a negative test effectively rules out a fracture for the knee. Radiographs are recommended for patients who are age 55 or older. They demonstrate isolated patellar tenderness without other bone tenderness, demonstrate tenderness of the fibular head, are unable to flex their knee past 90 degrees, or they're unable to bear weight immediately after the injury in the emergency department. And that's for 4 steps. It's important to remember that the diagnostic accuracy of the Ottawa knee rules presented in this slide has been validated only in adults and not in children. Multi-ligament knee injuries are not as well studied because thankfully they don't occur as frequently. And one of the classic multi-ligament knee injury patterns is called the terrible triad or the unhappy triad. A surgeon named O'Donoghue in 1950 called attention to that, quote, unhappy triad of 1, rupture of the medial collateral ligament, 2, damage to the medial meniscus, and 3, rupture of the anterior cruciate ligament. And this injury is often the result of a direct blow to the lateral or anterolateral leg or knee with the knee in near full extension, as seen in the photo of Tom Brady on this slide. The current evidence expands this injury pattern to include either the lateral or medial meniscus, in addition to the ACL and the MCL. So as stated on the previous slide, thankfully, multi-ligament knee injuries don't occur very frequently. Knee dislocation is the worst case form of a multi-ligament knee injury and requires careful evaluation to avoid serious and potentially life-threatening complications. So the most serious complications could be injuries to the popliteal artery and the common peroneal nerve. So there was one case that we had at West Point. He was a gymnast. He was practicing some of his like flipping and tumbling on a trampoline, and he injured his knee. Nobody saw him really do it. The athletic trainer evaluated him. He had the typical presentation of a swollen knee, and not sure what the exam looked like at that point. But the gymnast didn't think that much of it. Unfortunately, he woke up the next morning in a severe amount of pain with a hugely swollen knee. And he ended up having a popliteal artery injury, and he had to have an amputation of his foot. And so luckily for him, it was a very low amputation. He was able to actually get through West Point and pass all the physical requirements and be commissioned as an officer. But those are the type of things that can scare you, and making sure that you're doing a good, solid knee exam on every patient, it's particularly with these acute knee injuries. So knee dislocations really, they only comprise 0.02% of orthopedic injuries, although the actual incidence is difficult to estimate because the knee often spontaneously reduces after dislocation, which is likely what happened with this West Point gymnast. Both high energy mechanisms, such as motor vehicle accidents, and lower energy mechanisms, such as those that occur with contact and collision sports, can cause a knee dislocation. And it seems like you see like one or two of these every year with football. The mechanism is typically hyperextension of the knee with either a varus or a valgus force. Estimates of the incidence of popliteal artery injury range from 4 to 65% of knee dislocations. And unrecognized damage to the popliteal artery can result in limb amputation, as I mentioned before, in the case that I described. The incidence of peroneal nerve injury and knee dislocation is estimated to be about 20%. We saw another one of these with a rugby player at West Point. The location of the injury is frequently where it passes around the proximal fibula. And recovery of nerve function is poor and may result in chronic foot drop that requires the use of an ankle foot orthosis, which is what happened in this individual, unfortunately. All right, so that concludes the formal part of my presentation. What we're going to do at this point is I'm going to run through about 3 review questions, and we'll see how you do with those. And then I'll take any questions from anyone that's on that have to do with the presentation or anything that's orthopedics related in general. So here's the first question, and what I'm going to do is open up a poll here. And so whenever you're ready, I'm going to give you about a minute to 2 minutes to go ahead and read the question and put what you think is the correct answer into that poll. Give people a couple more seconds here, about 30 seconds to put what you think the answer would be. All right, so here's the results. So most people chose letter B. So let's first just look at some of the key information from the actual question itself. So joint line tenderness and delayed effusion, those are 2 of the main characteristics of a meniscus injury. And so you want to choose a special test to help confirm this diagnosis. So B was the correct answer. So the McMurray test and Thessaly test, those are the best tests for a meniscus injury. Obviously, letter A, the Lockman and the anterior drawer tests, those are for ACL injuries. Noble compression test, that's for IT band friction syndrome. Eli's test for quadricep or rectus femoris tightness. And your varus and valgus stress test, those are for collateral ligaments. So very good. So I'm going to go on to the next question. So I'm going to relaunch the poll. All right, so we got a fresh poll here, and here's the next question. Again, I'll give you about a minute to 2 minutes to put an answer in. Go ahead and read through the question. Put what you think is the correct one. All right. Take about 30 more seconds. All right, last chance. There we go. All right, so I'm going to share the results here for you. All right, so let's look at some of the key information from the question. So we're dealing with acute traumatic injury, falling up the stairs, which if that confused you, where they're kind of going up the stairs and they trip and they bang the front part of their knee. And so striking the anterior part of the proximal tibia. And there's bruising around the tibial tuberosity. Uh, what would be the most likely injury from this mechanism? So most of you chose either A or B, and there's one C. So I think one of the things that as a talking to our third year students as they're getting ready to take the board exam, much like you guys, sometime probably in July or next October. They're getting ready to take the academic PEAT. I don't know if any of you on here tonight had to take that as part of your program, but very typical of board questions that you'll find two answers that are similar as far as hard to distinguish between the two. So I think, some sort of ligament injury, I think would be the most likely in this question. But based on the falling up the stairs, if you think of the mechanism for a dashboard injury, so I think when you think dashboard injury, think PCL. The other mechanism that's a major one for the PCL is a hyperextension injury. But a lot of times you're going to see some sort of blow on the front part of the knee, the front part of the tibia that's pushing the tibia backward. So the correct answer is a sprained or ruptured posterior cruciate ligament. And ACL, that can be injured as well with hyperextension, so you do need to watch out for that. You'll between these two here, these are often kind of missed for each other. So the differential diagnosis for a patient with an acute knee injury with an immediate effusion is these two diagnoses. So this question stem here didn't talk about the effusion, but if you do get a question that says they have an immediate knee effusion, some of the differential diagnoses could be a patellar dislocation or an ACL injury. And the rupture of the popliteal artery, just not likely with this mechanism. That's usually more of a hyperextension type of mechanism. So I'm going to reset the poll here and we'll go on to the last question. All right, so I'll give you a minute to 2 minutes to take a look at that one. And we'll see how you do. Took about another 30 seconds or so. All right, last chance. Gotcha. All right. So here's the results. So we had everybody was either C or D. So that's good. So like I said, usually on these questions, you'll be able to narrow it down to two. And I think you got the two most appropriate runs. So let's look at some of the key information. So medial meniscus repair, thinking about what some of the precautions are with that, what exercise should be avoided for the first 6 to 8 weeks to protect the repair. And this is a pretty tough question. I think it makes you think about not only kind of anatomy and some of the like exercise prescription, but it also makes you think a little bit about anatomy. So think back to the initial slides when I talked about some of the anatomy and biomechanics of the knee. And what are some of those attachments to the medial meniscus? And so the one is the semimembranosus muscle that also attaches to the medial meniscus. So open chain resisted knee flexion exercises will also start to create pulling and tension on the medial meniscus. So like open chain knee flexion active assistive range of motion, no problem. But it's only that like resisted knee flexion exercises that are going to be the problem. And so that D is the correct answer on that one. All right, so that's all I have for the formal questions. And if anybody has any questions for me, probably the best way that we do this is that if you would just type your question in the chat box, and I'll just repeat it to everyone and kind of answer it to the best of my ability. So anything to do with the presentation tonight, or if you have any other orthopedic related question, happy to answer that as well. If you have neuro or like cardiopulmonary questions, I can do my best, but I wouldn't trust my answer if I were you. So.
Looks like you
So the
got one
question,
there, Mike.
yep. One question is a mechanism of injury for hyperflexion more common for ACL or PCL? I think hyperflexion is really not a real common mechanism for many sports injuries or just injuries in general. I think you might see it sometimes with individuals falling on like ice and slipping and things like that. To be honest, I don't think it would be a common mechanism for either of those two ligaments. I think what you would more be looking at there is if there is some sort of valgus force as you fall, which would be more of a mechanism for an MCL versus the ACL or the PCL. So that would be my guess with that one. Now, hyperextension, I think, like I said, that's definitely ACL or PCL, either of those two, kind of depending on the types of forces that are involved. But hyperflexion, I would say, is probably more MCL because it's probably more likely to be a combination of hyperflexion with some valgus type of force. Any other questions? Like I said, fire away. It doesn't have to be exactly related to what I talked about tonight either.
Well, some of you are maybe thinking about questions and writing them in the chat box and everything. Let me just comment on the fact that because I often hear this, when I teach the 2-day therapy ed prep course, and that is that so the clinical practice guidelines per se are not testable on the NPTE. You all know that the examination that you're going to take is based on information that is published in textbooks. But let's think about what makes up these CPGs that Dr. Crowell presented tonight. I mean, the CPGs were published, what are the dates? Like 2017 and 2018.
Right.
And
Yeah.
so that evidence is very well made its way into textbooks. And so the nice thing about the CPGs is they really provide one-stop shopping for a lot of the topics that you're going to be tested on with relative to examination, to evaluation and diagnosis, and then interventions for things like knee ligament injuries, knee cartilage injuries, hip OA, rotator cuff tears, and all kinds of musculoskeletal orthopedic injuries. So pay attention to those, and Mike and Brad Traeger, the two co-authors for our musculoskeletal chapter, have just done a wonderful job of creating these nice synopses in that chapter. And so you got that information in the review and study guide, and we encourage you to take a look at that. If there aren't any other questions, then first thing, I just want to say, Mike, huge thank you for just another outstanding presentation this evening. I always appreciate your overview of these clinical practice guidelines, whether they're the knee injuries or other ones, and love the graphics, love the video clips, and also for most importantly, just for helping the students to prepare for this examination that they're going to be taking. So thank you, Mike, and students, thank you for joining us, and especially because I know that this is you're on your semester break or holiday break, and we're just grateful that you took the time to be a part of the session tonight. Good luck to those of you who are going to be taking the examination coming up in January. Good luck to those of you who are going to be taking the examination in April and later as well, but especially for those of you who are going to be taking the examination next month. And happy holidays, everyone. Be safe. Have a wonderful 2024. Good night. And best wishes for success on the NPTE.